We have a perfect group here for this fun topic. And Tom's searching for a writing instrument. Let's see. Well, welcome everybody. So I think everybody knows what we're trying to do. We are trying to set a methodology and framework to hang all of our various work off of. Let me, I'm a facilitator, and probably the best adjective for me is I'm a rude facilitator. So I'm going to do something a little rude, but we're going to jump in pretty quick. Mladen from South Africa, Rosanna from Peru, Axel from the US. He happened to grow up in Germany. Baron from Nepal, Brian from Ireland, George from Ghana, Mohammed from Bangladesh, Saba, a lot of work in UK, but in Netherlands, Shauna from Canada, and Jinkun, otherwise known as Alan from China. What a wonderful group. Saba, why don't you start off and talk about your framework and methodology work in the past, if you don't mind.
Yeah, of course. And thanks for sharing the document, which I hope some people had the chance to at least skim through. I've been having conversations about this with Tom and the team, also with Shauna in the past, and also with Mladen, actually. So what we were trying to do at the time is to say, are there indicators that we can use to measure the impact of health technology management in different countries? And that was a starting point to say, well, actually, we're never going to find true causation, but some correlation in different countries might be possible. And we, as you can imagine, we came across many challenges and pitfalls in doing that. But at the time, Yadin David had shared an interesting paper with me where they said, well, okay, we can look at some proxy indicators, for instance, patient safety in a hospital and patient safety incidents. So maybe you can say that the involvement of more clinical engineers in a region or in a hospital can lead to less errors over time. And so that was an interesting paper of work that they, I think, was conducted about, in 18 countries, maybe some 10 or less years ago, 5, 10 years ago. And we took that as a point of inspiration to say, well, what are the other indicators that we could be using to also demonstrate that actually clinical engineering makes a difference, it has an impact. And I come from a background of sort of some evaluation studies. So I used to be an engineer and I've become a social scientist. And one of the things that I've helped develop other teams are theories of change. So, what are the sort of the underlying assumptions you make about how certain activities lead to certain outcomes, big outcomes? And then we work backwards to say, okay, if big outcomes is better health outcomes, less errors, just general stronger health systems, what is the pathway that we can use to say actually that was partly contributed to, and not true attribution, I have to be careful here, a contribution of that was made by clinical engineering capacity, expertise, presence in a country, or in a hospital or in a region. And so I really like what you proposed, Tom, that actually if we take some case studies, a use case like pulse oximetry or something, maybe we can just follow some stories through and populate this big theory of change model. But I do need input also from people here in the room to say, A, does that use case make sense? And B, what are the indicators that we could then use to demonstrate this potential change logic from having clinical engineering presence, expertise, etc., to the good outcomes that we want from a health system. Does that give a good background and overview, Tom?
Yes, just talk for a moment of the structure of the study you were doing a couple years back.
Yeah, so what we were looking for, where our starting point was actually the available documents we had from Adriana, which was all we had at the time, right? I know that the medical device atlas and is being updated at the moment, and everybody's putting in updated information, but we took all those country profiles to get a sense of, okay, what does each country have in terms of health technology management? And so that would be our starting point to say, this is what they have. And our plan, we didn't go with it in the end for various reasons. Our plan was to then say, what are the indicators in those countries that we can use to demonstrate patterns of how there's a correlation between good health technology management or strong health technology management in a country with good health outcomes, health system outcomes in that country. And I know, Tom, that at the time also some indicators and data was being collected on what we mean by strong clinical engineering presence or clinical engineering capacity in a country. So I don't know about that side of things. I don't know who's been collecting that data and how far it got. But yeah, I would really like to then see, okay, is it viable? Does it then make sense to correlate clinical engineering activity with some of these big country indicators, or do we go for something a little bit more regional, which makes sense to me, or even at the hospital level, so a health provider level, where these clinical engineers are operating? Because any other studies I've seen that have done that have really struggled, and usually that correlation is very poor when they try and expand to a system or country level. Sorry, someone was trying to say something. Yeah.
I mean, I want a lot of people to say something in a minute. So you are part of a university or a United Kingdom university, and you also presented some of the early discussion at the Appropriate Health Technologies program in UK a couple of years back.
Yeah.
Just tell us who you were affiliated with. I want people to realize.
Sure. So at the time I was with King's College London. They actually do have a very strong biomedical engineering program, an undergraduate program, but also some master's courses. And they train a lot of the clinical engineers that end up working in the NHS. And I wasn't in that department, but I've taught on it more on the health policy side for those students, and also general health technology management and how you resource it. I now moved to Delft University of Technology. So I'm now in the Netherlands. So I'm still affiliated to a technical university, but I work on health policies. So that is my thing. How do you measure how strong a health system is, and how do you make it efficient? Which is why on the health system side, I'm very happy to provide that input, but I do need support and help on methodology on how do we measure good clinical engineering so that we can make that matching or that indicator match of some sort.
Great.
Mladen, I know you're on the call and you had some interesting thoughts, because I shared these ideas with you and I haven't had time to read into your email in detail. So perhaps you want to jump in and if you've got some ideas in response to the questions I raised.
Yeah, thanks, Saba. Actually, you've caught me kind of unexpectedly, because I've just been putting together a framework that I'd also like to table as part of this discussion.
Okay.
But perhaps let me look back at what I did send you, if you don't mind, and then if I do have something useful to comment, I'll come back later. Thanks.
Okay.
And Mladen is a framework guy. I mean, he thinks that he dreams in terms of frameworks. So
yeah, so that's what we need.
I'll just mention that we've had 4 others join since you began your discussion, Saba. Fabiola from Mexico, Elliot from the US, Tazeen from Pakistan, and Dr. Manish Kohli from the US. Are there other questions for Saba of what some of the things she said, of the research work she did, and in some ways continues to do around how does health technology management contribute to better health outcomes?
Yes, if I may.
Go ahead.
Okay, sorry. Well, I think that Saba presented, hello, this is Fabiola from Mexico. It's very important, and I totally agree with trying to connect the clinical engineer efforts and achievements with the major health indicators, because in some ways we may indirectly this study by trying to analyze the impact of technology into the health programs, national or regional health programs. And in some way, the regulations and the official documents may present clues about the participation of technological staff, clinical, biomedical engineering, technical engineers, etc., into the outcomes from these programs. Sometimes it's very directly, sometimes it's not, but this is what we may begin with. And I think the theory of change is a very reliable tool to begin with. So I am with you, Saba. Thank you and congrats.
Saba, maybe say a little bit more about the theory of change.
Yeah, so a theory of change sounds really fancy, but it's a very simple diagram. And it's what social scientists like to use, right? For health systems change. And so what it looks like, since we're engineers and we like to think in pictures, I'll try and picture it. I don't have a whiteboard behind me, but I'll say it with my hands. So imagine that you've got a bunch of boxes that have arrows between them, basically. And the first box that you see are your inputs. And by that, I mean, you also call them activities, right? So there's things like, what are our activities? We have X many clinical engineers on site. This many of them have been trained and can do X skills and have these X skills, for instance. Let's just take those two for the sake of argument. Maybe we also have something to do with governance and reputation or something of these clinical engineers and their influence. We then go in, we then track to say, okay, if we have these inputs and then we have these activities, what does it lead to? What are the very first outputs that we see as a result of that? And the result of that might mean, and it depends on where you cut the cake, really, you can draw it in different ways. The result of that might be, okay, we had these engineers, and look, as a result of that, X number of hospitals were served. So they're more quantitative kind of indicators in the outputs column. Yeah, X hospitals were served with them. We had X hours of their time available, and we had X number of reduction in patient errors from X to X since the year they started, or something like that. So, and for each of these indicators that you choose, for some of them, you can probably find very good evidence and you can really trace back real causality. For others, they are more indicators or patterns of activity that are sort of more qualitative, right? And that's okay. Different programs have different degrees of evidence to show change. Then as a result of that, we follow that through and we say, okay, if you had those direct outputs, what's the next box will say, what are the wider outcomes that resulted out of that? So the wider outcomes that resulted out of that could be perhaps more prepared and efficient service delivery in those health providers of those countries. And you can track those case studies and provide evidence of that. And then the final box is usually the big impact box, but that tends to be the real long-term change. You know, if you follow all these steps through, at the end of the day, what you want is in 20 years, if we keep doing this in our program as programmatic change, we will have health systems strengthened, right, as a result of these, because we are demonstrating that we make a contribution to health system change. So these theories of change, they tend to be used for more programmatic interventions, but I would imagine that something like this is something which lends itself to that kind of framework as well. I would love to see, Mladen, what you've got up your sleeve too, and maybe we can even have a separate discussion to share ideas of what that might look like. But it's just a simple conceptualization so that if we take, say, the pulse oximetry example, or we take some other case studies from different countries, we can place them somewhere in a visual way, and we can decide which of those things that we want to demonstrate could we have real hard evidence for, like actual indicators where we do show either causation or correlation. And those will be our strong arrows between the boxes, and the other ones will just be more exemplary. I hope that makes sense, Tom, as an overview. I see a hand.
Makes great sense. Go ahead. Who's got hand up?
Rosanna. I think it was, but I'm not sure if it was a real hand.
This is Rosana Rivas from Peru. It's not a question to Saba, it's a contribution to this important session. I come from the academic arena, and hopefully for me, I have gradually been engaged with the nonprofits and other nonprofit institutions outside and inside the country and in the region as well. Gradually in the process of development capacity buildings and searching for impact outputs, evidences, we have been, when I say we, is because I have not worked alone. This is a process that was ongoing and increasing in knowledge and smartness with colleagues, mainly from American College of Clinical Engineers, and then with the IFMBE, and then with the GCEA. Gradually, and I was saying since 2006, things are going more and more clear for us in the low income and middle income settings. This is again not an answer to Saba. This is a contribution about capacity buildings and impact outputs. When you realize that the needs are high and higher gradually, when you realize that perhaps even you are member and professor, researcher at the university, blah, blah, and with respect the blah, blah, I'm just trying to be landed in the ground. When you know that these organizations has their own and respectful dynamic timing, and the community, the countries, the patient has another dynamic, another timing, you gradually realize as well that there is a need to change, improve, and research more to go and achieve the objectives. This is something was exchanged at the Clinical Engineer and Health Technology Management Congress in Washington. I was hopefully able to be there in presence, but the regional meeting in the Americas was a nice moment on which these topics were shared. I'm sorry, the videos I realized that are not yet in English, are just in Spanish, but be sure I will work so far, much in making in English to be global. You need to have this feedback in English as well. All the regions, all the meetings, regional meetings are in English, but not America's one, and this is something should be changed. Well, so the change in the methodology, we talk about it there, and now in the recent reunions, to think about the methodology implies more than planning the contents. Of course, make some extraordinary efforts on using maps, using mind maps, using research tools, but more than that, beyond that, if the attendees are not exactly just engineers, are healthcare staff, healthcare workers, you will find there physicians, you will find there nurses, you will find there also engineers, but not exactly, again, LMICs, low and middle income settings, engineers from diverse specialties. So you need to talk their language. Do you need to engage the needs in common and show gradually how clinical engineer, how health technology management, even now, health technology assessment applied to medical devices respond, improve, is good for the needs they have. And the evidences are very strong, are extremely positive. And the last one I said the last time, it was in Haiti, in the middle of the crisis, in French, with the people surrounded by violence and several problems. And it was successful, 20 health workers, including engineers. And the added value of this method to work and this approach is that is multidisciplinary, is engaged with solutions, and the outcomes are directly in what are they going to do immediately after the workshop or the training or the course. And this is not a fancy question. This is something they are working with us through the course. So there is not an answer, a theoretical answer or an emotional answer at the end of the course. It's something they are working with us among the course. Thank you, Tom.
Rosanna, say a little bit about the training in Haiti.
The course was, I don't know the number, since 2006 is the last one. And each time the contents are improved. This time was online or full online. Sometimes it's presential, but this one was online. 3 tutors and the leader, Toby Clark. It was funded by Pan American Health Organization. The attendees were healthcare workforce, diverse, including engineers, women and men, and the cases were engaged from practical cases, which means we have meetings before the course was done with the people, with the attendees. Contents are health technology management, health technology planning, health technology regulation, health technology assessment criteria, 2 medical or 4 medical devices, and also, of course, added value of human resources management in the middle of this complexity arena. No? It was very successful, and it was done in French, of course, because all of the people know more French, but as well, some of them talk English. So when we had 3 sessions in live, Zoom sessions in live with all the participants, those ones were fantastic, not just because of the contents, but also because of the strong motivation, engagement, and commitment from all the participants in English, in French, was terrific.
Okay, thanks a lot. I've just gotten my desktop to work, which will help.
Hello.
Yeah.
Can you hear me, Tom?
Yes, we've heard everything. Thank you. I'm not on mute. Good. Let me summarize. First of all, Ashnafi from Ethiopia, also representing many parts of Africa, has joined. And Khalil, I think I mentioned your name earlier, from Brazil. Just wanted to make sure I didn't miss you. Let me summarize for some people that have caught up, haven't been able to hear the whole time. And quickly, Saba described the theory of change in 4 boxes. The 4 boxes were inputs to the health system, you could say, and it's CE activities as we've described them in these previous meetings. Described a next box is outputs of CE into the health system. And these are the kinds of indicators we've measured all of our careers, and we're very familiar with them. Hours of clinical engineering service, and PMs done, and maybe reduced patient errors if we're getting more, and so forth. And so we've got a lot of data around that. Saba, I think you were asking what was some data maybe from a couple of years ago, and we published, we did a study in, 2017, 2018, published it in 2019 in the Journal of Clinical Engineering, the success stories of clinical engineering activities, 400 success stories in 125 countries. I think all of that really is about these first 2 boxes. The third box you described, Saba, was the wider outcomes, maybe where we get into how digital health, and our ability to integrate medical devices into electronic health records reduced ICU days or something like that. When we get into more significant, bigger than clinical engineering outcomes, wider outcomes is what you call that third box. And there's a fourth box, which, I don't think we've tapped yet, which is long-term change, a long-term impact as a result of our activities. What was cool about what Rosanna shared was she started with, WHO maybe in the 80s started to work on these, what were the CE activities that could make a difference. And that led to ACCE and the ACC workshops, 50 of them. But then that spawned off, this and I'm not claiming all the credit for the ACEWs or the ACC. It engaged many of us in our hearts and minds in lots of different ways. It's not just about ACCE and these workshops, but people like Toby, who was deeply involved in that, began with PAHO working across Latin America, and Rosanna's worked with him, and she cited the work beginning in 2006 that started working within countries, I think really working on these inputs and outputs, and we could probably figure out wider outcomes as a result of those. And one particular case study she talked about was in Haiti. And Rosanna also brought up the fact that, this is not only the clinical engineers, but as we learned very early in the ACEWs, it's really about engaging health leaders, decision makers, clinicians, and so forth. So the stakeholders and finding evidence. Let me stop for a moment. Shauna, I wanted to call on you. I'm glad you raised your hand, because I know you talked about how the case study approach can help us kind of get from the blah, blah, blah theory into actually what happened. So go ahead, Shauna.
Great. Can you guys hear me?
Yep.
Great. Nice to see you, Seba. And I apologize in advance if my brain hasn't caught up with the 2 cups of coffee I've just had. It's just 6:30 here and I'm a little bit slow.
You got a
this
good
morning.
smile no matter what. Go for it.
First of all, I think the theory of change model is a great one to use. I think that for a number of reasons, I completely agree with you that we've talked about this before. There's been a lot of interesting research done, but we can't, I don't think, start from a place where we're looking for causation necessarily. I think we have to start with seeing what's correlated. And I think that the model is a good one. And I personally am excited about the idea of using it as a broad kind of methodology or framework where we start to pin different studies and different documents and resources that we're looking at that demonstrate and quantify some of the particular components of those different places in the theory of change model. So yes, I'm totally on board with that. I think it's a great way to start. I also think when you mentioned study that potentially Yadin had done or had been involved in around kind of proxy variables or proxy measurement, I think that's really interesting to explore because we could look at what those proxies are as well. You mentioned quality and patient safety. There's obviously a lot of research in particular areas like anesthesia or ICU around patient safety that we could look at as well. And I think, and again, my brain's a little bit fuzzy right now, but I think if we do start with this broad framework and we kind of agree what we're looking for in each of those big buckets, that as we're collecting evidence and starting to pin things in different places, we'll probably start to be able to zero in on a couple of interesting looking areas where maybe there's more evidence. And in terms of kind of level of detail and what we're looking to do with this work, you're right, Tom. Last time I talked about stories. I think stories are very powerful, and I think we shouldn't discount the kind of value of bringing stories together that speak to certain areas in this framework, but also that if we have this model that we're using and we're working within it and we're kind of evaluating different case studies that we find within this framework, that's going to really help provide some I use the word clarity when my brain isn't particularly clear right now, but provide some kind of clarity as to what areas we would then want to zero in on more in the future, or if there are certain areas in that model where community-based interventions, there's a lot of data on those, for example, from the global health world, that we could start to look a little bit more at that. Those are just some initial under-caffeinated thoughts.
Very, very nice. Elliot.
Hi, everybody. Good to talk with all of you. One of the challenges I think we're going to have is that we're discussing many different environments that have different priorities and different capacities. And one of the thoughts that occurred to me is we may want to use as a tool and also a visual a maturity model kind of approach that has been well adopted in other areas, so that we can articulate different kinds of organizations in different stages, and it's measurable in each stage, and also shows the evolution that happens. The evolution happens in infrastructure. The evolution happens in ICT. It happens in logistics. There's so many aspects of this. HIMSS has for 2 decades been using this electronic medical record adoption model, which has stages. It's based on this on the general framework of the Software Engineering Institute's CMMI. And then what HIMSS has done over the years is show year over year how the different organizations have evolved. So you can't build a state-of-the-art computerized information system if you don't have networks. You can't build a state-of-the-art anything with communication if you don't have some security tools. So there's layers that have to be built up in organizations, and HIMSS over the years has also built a number of additional maturity models that kind of interlock and dovetail. Because we have change happening. We have home care that has been accelerated out of the pandemic. We don't have a lot of history and documentation of home care. We're writing a book on it while we're actually creating it. And so there are many areas. Perhaps we can mimic some of the HIMSS work. Perhaps we can and should create our own, because we should have our own way of describing to each other and to the policymakers, the funders, what we consider to be reasonable stages of growth and evolution. And each one of those has a change process. It going, within one organization, and as you go from level to level, and circumstances, economics, technology, all kind of are disruptive. AI, cellular communications, broadband communications, all change things. And so I think that that's something for us to look at. And as a clinical engineering leadership organization, I think we have an opportunity and maybe an obligation to create such a maturity model that others can refer to and help us communicate better, market, educate, advocate for the work we're doing. Back to you, Tom.
Go ahead, Sab. Manish, physician perspective, go ahead.
Thank you, everyone, and good morning. And what a fantastic discussion. I want to build on what both Elliot and Saba have articulated. As I look at digital maturity globally, one of the key challenges we have is lack of people, and also a risk that people can make expensive mistakes if we follow the old way of doing things. And I truly believe if we think of a framework where we think about CEs as part of a broader team that are helping drive that change on the ground level, because I think there's a unique skill set the CEs bring to the table, knowledge of technology and knowledge of healthcare. And I think in driving change, especially in low and middle income countries, there could be key anchors, at the community level, but also at a health system level. And as I think about digital maturity, building on what Elliot just shared for HIMSS, let me just share the slide. It's really goes much beyond just technology. It's really how do we begin to look at foundational components, governance and workforce around data stewardship, privacy, security, and these are conversations that I think CEs must be part of. Not only because of the strengths, but also devices are going to be an increasingly central component of where healthcare is going, especially as we look at non-hospital-based care. Interoperability. Many countries are not even thinking about that. We can digitize different units, but if we're not sharing data, we've really not moved the needle. And how do we actually begin to get into those conversations that allow thought leadership to percolate across the ecosystem so that the right frameworks are in place at the country level to mobilize data. And I would even say it internationally. How do we begin to share data regionally and across the world? I mean, this is absolutely critical. And then once organizations have data, and interestingly, the industry that has the largest compounded annual growth rate for data is healthcare at 36% annually. So if we digitize everything and bring data to bear, we're simply going to drown people and starve them of wisdom. So how do we begin to look at next gen technologies around AI and other things that allow us and health systems at all levels to glean insights for better decision making? Because I think that really is what's going to improve outcomes. If we are able to contextualize insights for every stakeholder in the healthcare ecosystem, so that at the point of decision making, they're making a better decision. Over time, it really strengthens the health system and creates the change that Saba, you've talked about. And then, really looking at how do we connect ecosystem to build digital capacity. And then the ultimate goal is to address population health and well-being at the individual level. So I am actually super excited that we're having this conversation, because I think if we can pull in CE, think about what skills we need to think about developing within the CE community and bringing them to the table at all these levels, is going to strengthen our ability to navigate change in a meaningful manner. So I'll pause there. So thank you.
Thank you, Manish. Saba, I know your time's limited.
Yeah, thank you, Manish, and thank you, Elliot, also for sharing the maturity model. I know we've had email exchanges about that in the past. So I'm going to suggest something that I hope makes sense also to you, Elliot, and tell me if it's not controversial. but I actually see the theory of change model and the potential maturity model as being complementary and almost sitting at an axis with each other a little bit. So and I realize that, of course, it makes sense, because today in the crowd, we have people focusing on capacity building. We have also people focusing on the methodology for the health outcomes, right? The sort of the impact of clinical engineering. So if say we took that theory of change model and we develop these indicators through all the methods that Shauna summarized nicely also, I hope this has been recorded. I know it has been. So if we say we take those and we capture those and we find ways of capturing those, we can build and already start populating that through some national databases, or maybe later on also through some stakeholder input. So we'll see how far we get. And it feels to me that if we have a good portfolio of those, parallel to that goes the capacity management of clinical engineering itself. Like, so clinical engineering itself goes through maturity, different stages of maturity, right? And so for that, to me, that's the capacity management piece or the capacity building piece. And the other one is the impact piece, but they do intersect, because as the maturity for clinical engineering in a region or in a nation, a health system matures, as it increases that maturity, you then enable that health system impact change further, or you catalyze it, or whatever. So there it is like this, I do think, but the advantage of them also being slightly different in terms of the data we would collect for it is that we can probably run these two things in parallel, Tom, I would suggest. So my suggestion would be that we do get started on a draft theory of change, populated to the best of our ability ASAP. I don't know what resource we have, but we can talk about that offline, Tom. And then at the same time, I really would love to see a maturity model develop and have touch points where we come together as a big team again and see what are our points of intersection in populating both of those models. But I think they serve different purposes, but they're also complementary. I don't know if people agree with that, but at least in my head, I visualize them in that way.
It's very good.
So if I can speak up, I think, yes, you're correct. They are complementary. They do tie together. And, one way to approach this from a community project perspective is using a spiral model, where you start at the center at some reasonably small task. And in the spiral model, you incrementally add to the complexity of what you're working on. So you have a crawl, walk, run, managing risk and time investment along the way. And it's also an agile model. So we could look at these starter blocks and validate the starter blocks, which might be the level 0 or level 1. And the association, the organization, CED, can become the authoritative voice for what each of these maturity levels represent, and also establish the methodology, the change methodology that we're going to use to document and support or sustain or educate change. And the spiral model could be the model that we use as an organization over a series of months and years to tackle this. I mean, the HIMSS maturity models weren't built overnight. They took years and years of meetings, discussions, dialogue. And you look across the meeting here, we have Peru, we have China, we have US, we have Nepal, Mexico, Pakistan, we have South Africa, we have voices and expertise all over the world. And we all have to learn a language that allows us to dialogue and fill in the various boxes within the constraints of our own time, energy, and understandings.
Thanks, Elliot. So have you been hanging out with Fred Hosea? I was just thinking about complex diagrams. But no, I appreciate it deeply. I want to get others to make comments that have been waiting quietly. Are there others from our group of 18 here that are that have things on your minds?
Tom, there is a hand.
There's a hand, Tom.
Go ahead.
Jenkins.
Go ahead, Alan.
Okay, thank you, Tom. Hi, everyone. Yeah, I just want to provide an observation, also anchoring what Elliot saying about the maturity model about the IT. Based on my observation and based on my previous working experience in the clinical engineering, hospital-based, and also the IT department, hospital-based, it is true in the IT section, there are a lot of the third-party evaluation to evaluate the IT department performance and even the hospital's performance on the ICT technologies. While in the clinical engineering, so far the only quite basic and general model, as I mentioned in the last meeting, is AMI's HTM 3 levels, like the basic level, medium level, and advanced level. So I also want to raise a question. Anyone else see in the world, any place they have a model, some maturity model for the hospital-based clinical engineering? And I also want to suggest we may put these into in particular, the capacity building project. So different levels of the HTM or the clinical engineering. Over, back to you, Tom. Thank you.
It's a very good thought that we can work on. I mean, where my brain got stimulated, I suppose, in the discussions of the last 10 minutes was looking at, I'm very familiar with the EHR, EMR maturity model, stages 0 to 7, where 7 is 0, everybody's not using the electronic medical record, and 7, everybody's using it, everybody's engaged, and it's being utilized in ways that actually improve outcomes. And I can imagine us putting HTM in the 0 to stage 7, take a little bit of work, but, and things build on each other, as Elliot said, so it's not absolutely simple, but I see that as one way forward that could be tackled this month. I'm sure other people are thinking multidimensionally beyond what I just said.
Tom, if I may add,
Please.
I also believe there's a great opportunity for innovation. Maturity models are great, but they do tend to be more hospital-centered, where you're looking at maturity within a hospital health system. While we need that, when we look at low and middle income countries, there may be opportunities for innovation. Example would be, if you're looking at a country like India, there's some portion on a patient-centered record where you essentially begin to create, what they call digilockers that create the ability for a patient to have access to all their records and be able to share it with the provider. So not only looking at the hospital maturity digitally and outpatient maturity, but really looking at new model of innovation, and that I think is an area ripe for action, and it's not going to come from sitting in a Western world where we have sort of gone down a pathway. It's really going to be engaging folks on the ground there who are looking at how do you solve problems at scale, at fraction of the cost at what we have spent in the West.
Manish, while you were talking, help me, give me feedback whether I'm thinking right, but I'm imagining our theory of change models, the 4 boxes we talked about, and measured by indicators that we have so far. I'm thinking about our maturity model we've already described, but it's like innovation parachutes into these models somewhere, and maybe as a short circuit to get way up the chain quickly because of a new way of doing things.
Bingo. Absolutely. Well said, Tom.
Tom,
Yep.
is very nice the point stated by Manish. Digital health, as Elliot stated as well, is an essential component to make the change happen. And it's true, my focus is really based on the making decision processes and changes in charge of the people, healthcare workforce in the locations. Digital health was gradually among the years in these training processes I've been engaged, not just in Peru, but in the region, and recently again in Haiti, was one of the most common initiatives promoted by the Pantenis. So it's a bridge, a practical, a very easy bridge for us to make things happen through the capacity building processes. I am just wanted to say that I'm very glad to participate here. I am respectful and very glad to meet all the colleagues here. Probably my focus is now, and because of the situation of my country and the region as well, more focus than in the research approach. Although I am a researcher, I am more focused now in things changing and make evidences of my own and my team contribution. Things are very tough in the LMICs. Time is short, and we all want the well-being of the community. Thank you.
Thank you. Good stuff. In fact, just before Fabiola and Mladen, Saba, has there been research around decision-making processes and how people get contributed? I mean, I'm sure there has, how people contribute to that. Maybe a quick comment, because that sounds like a vector we're choosing.
I think that's an interesting one, and I'm really happy you raised this, Rosanna, especially also in the global health research and health system strengthening. You've got so much also on engagement, co-participation models, participatory research, all of that. I'm actually writing a book chapter about it with colleagues right now, just for health systems research. So yeah, we can draw on a lot of that is the short answer. I really want to hear what Mladen has to say before I go in 9 minutes.
Ladies first, Fabiola.
Yes, very briefly, I totally agree with the strategy from Saba to meet two teams that work together into 2 different models may be interesting in order to compare, including all the elements we have said so far, and to converge into a basic set of indicators for us, for clinical engineers, and to share them into the stakeholders, ministers of health and policymakers, in order also to push into the agenda the technological resource issues and the biomedical and clinical engineer participation into these programs. Finally, with digital health, I expect that this topic will be included constantly into the discussions of the programs from now on. So this time will be very strategically important for us to put it into the table. So totally agree, and well, I am in. Thank you.
And everybody recognizes Fabiola is a bridge between both groups also. Mladen?
Yeah, thanks. So very interesting discussion. I officially retired last week. So I think it's just in the glow of the aftershock, I find myself somewhat confused as to what we collectively are trying to achieve. And in doing that, I went to the meeting of March 11th, where it said that the two main goals in terms of capacity building are having enough of the right people with the right education, training, and appropriate management skills. And the second goal in terms of impact measurement was measurable impact on clinical outcomes. And if that still stands, and I assume that it does, the question is, well, who is our audience? We're not having a kind of insider discussion. We are trying to convince stakeholders out there. And if we try to convince stakeholders out there, we need to convey a clear message that's easily digestible and links to healthcare delivery across all jurisdictions. So with that in mind, Saba, I did have a look after you posed that question to me as to what I had sent you. And I'm very happy to say that what I'm going to share now is still very similar to what I had shared then. So if I may share the screen, just 4 slides. Let me know if you can see them.
Yep.
Let me see.
And while you're
So-
bringing that up, Mladen, those earlier definitions were our starting point. We're allowed to change them, but you're right. The external audience is hugely important. Go ahead.
Yeah, sure. So can you see my screen?
Yeah.
So if indeed, in fact, we're trying to measure clinical outcomes, we need to talk the language of healthcare. And we all know that the buzzword rightly so, or the buzz term rightly so, is universal health coverage at all levels, in all jurisdictions, in all countries with varying levels of resources. And so if we go back to the World Health Reports of WHO 2000, these were the health system performance measures that came out of that. Coverage is the probability of receiving an effective health intervention when needed. And effective coverage digs just a level deeper, looking at essentially the ratio of effectiveness to efficacy. So the question that arises from this is, how do clinical engineers and health technology managers contribute to coverage and effective coverage? And part of that is access. So, Adriana always mentions access to medical devices as being the primary goal. So what do we, clinical engineers, health technology managers, do? How do we do it in promoting availability, accessibility, affordability, and/or acceptability? Then if we go on from that and kind of now we're moving away from access and coverage to actually how well we are doing in terms of the quality of care, I always go back to the Institute of Medicine criteria for quality of care. And those are safety, timeliness, effectiveness, efficiency, patient-centeredness, and equity. So again, the question arises, how do we individually, collectively, across jurisdictions, contribute to achievement of those 6 indicators of quality? And then we could dig further. For example, if we look at the regulatory space, this is what I drew up some time ago in terms of a regulatory framework in South Africa. How do we collectively contribute to these different aspects? I'll put this in the chat so you can look at it later. I'd love your comments. And then last but not least, this is from the WHO's framework for action. So if we accept that we are making all those impacts, it's then very useful to show in this diagram where in the process and the results we are making those impacts. So it can link up to other components and other contributions within the health system to be able, so that we come up alongside those. So those are just my thoughts for now. Thanks.
George, I'm gonna have you speak in a moment, but Saba, responding to Mladen, which model do these fit best into?
This is perfect for the theory of change. So thank
Okay.
you, Mladen. And I forgot to mention, but I'm glad you put it up in that last slide, Mladen. The WHO has been using theory of change models for a while, also in the health system strengthening reports, as the example that you just gave. So we will be speaking that language, which is also why I thought we should use it. So I'm glad there's a lot of united support for it today. So Mladen, you're basically solving what we can add in those further two more boxes, basically, I think, with those equity, access, accessibility, etc. So I think all we need to do is create these buckets, as Shauna called them, and then put in the data in order to collect and actually show how the indicators populate. I have to go for another meeting, I'm afraid, but give me homework and Tom in my absence, and I'll get to it, and I'll even see if I can find some student resource or something for it. But I see Elliot's answered my question also, but yeah, happy to see who it is that we need to work with and who can volunteer their time as well. Yeah.
And by the way, by May 1, we'll have 3 interns that'll be able to work on this full time. I mean, full part-time.
Yeah,
20
yeah,
hours a week.
fair enough. Fair enough. Any help would be fantastic, and we can be quite hands-on ourselves, I imagine, right? So yeah.
Great
Okay.
job, Saba.
Thank
Enjoy.
you. Bye.
George.
Hi, good afternoon, everyone. To me, I'm extremely excited about this discussion, and I feel like this is a dream come true for me when we're able to finish with the identifying the key indicators that will help us measure the impact. It reminds me of a project that I abandoned, my thesis, way back in 2014. I was trying to measure the impact of medical equipment on quality healthcare delivery in Ghana. That was my master's thesis. And I ended up abandoning the project because I was unable to get the variables that I was looking for, especially in terms of getting data to support this. So in that research that I was doing, I came across the quality of change, the change model that Saba mentioned. And so I'm very much aware of the change model and then how it works. But with the digital maturity model, I'm not too familiar with. So I think this is a dream come true for me. If we're able to use these 2 models, the quality, the maturity model, and then the change model, to be able to identify the set of indicators or processes that will help us measure the impact, that would be great. Thank you.
I think we've thrown out a lot. Thank you, George. And it gives me some historical context way back in 2014. That, for some of us, that's not so long ago, but anyway. I think we've moved at a dizzying pace this first hour. I think there's not perfect clarity. I think we get that, there's 2 streams here, and both of those streams, the theory of change and the maturity model, are impacted by innovation. We're trying to be able to speak the language of the people maybe we report to in the health systems, not only within. It's not perfectly clear to me how all this fits yet, but we're gonna, Calroy and I will work over the weekend to, get the transcript moving and to try to tease apart what it is we've said. And I'm not trying to be dense on you. I mean, we're getting closer to the mark. I don't think it's perfectly clear yet, but I think we're getting closer to understanding. And I think the things that got said will make it clearer if we tease them apart. All right, I see a hand. No, I don't see a hand. Who would like to share next? In other words, I've already had coffee, Shauna, but I'm still, confused. But I'm not as confused as I might have been. Go ahead, Manish.
I do need to drop off. So I just want to thank everyone. It's been a great conversation, and I look forward to the next steps.
Thank you. Appreciate it. So does it make sense for the capacity building to work on the theory of change piece after we provide this clarity of what we've said and the impact to work on the maturity model? Does that make the most sense?
I think it's the other way around, isn't it?
Okay. Yeah, that's why I'm asking.
Or do I have a different interpretation? To me, the maturity model makes sense for capacity building, like how.
I think you're right. Yeah, the
Yeah.
way I described that 0 to 7 earlier in my mind, and as Rosanna was saying, the 3 maturity model or HTM models from Amy, that fits into that side. So
I
that
think so.
maturity model, capacity building, theory of change, impact. It even makes sense when you think about it, right?
Totally, yeah.
It does.
We think together in the 2 models, and indeed, Tom is indeed 2 processes engaged closely. I'm very glad about this session. It was intense, not easy, but it's clear that the experiences and approaches from all the participants are making this more valuable and pertinent. You know, each one has their own staff after the session, but all of our staffs are engaged in healthcare. So thank you all for your contribution today.
I think we might end early. You know, it occurs to me the maturity model fits into what Antonio has said to us about, you know, various progress along the continuum, you know, different places, different resource countries, or different places along the continuum. So that maturity model matches that nicely.
I
Go
was
ahead,
just going to point out, we don't need to go to 7 levels, and we don't
Yeah.
need to be held to 3 levels. The generic maturity model that CMMI developed, or that was developed by the Software Engineering Institute, is 5 levels. So, you know, we can fill these boxes in as we feel appropriate to
Yeah.
our community and our goals.
Agree. What maybe my last question, and it's okay if others, Milad, in just a second, if others come up with new things to talk about in, you know, in the 25 minutes we have scheduled here. I guess my next question is, what do we want to do with the 3 case studies? I think they fit across all of this. I think they fit across how they've affected clinical engineering, how clinical engineering's affected them. I think they have changed decision-making in healthcare, the pulse, and I'm talking the pulse ox, the oxygen concentrator, and the ICU ventilator. But anyway, over to you, Milan.
Thanks, Tom. I also need to leave soon. Just to make the point, and goes back to what I said when I started my comments earlier, I am somewhat concerned that this is the sounds of a research project. So what I would suggest is that there are, in fact, activities at 2 levels. One is a research one, which I think is very important, because that is really, you know, generating the evidence, which is very important. But I think there should be equal emphasis, if not resourcing, but equal emphasis on what we say to the world out there. So I think there's a lot of low-hanging fruit, particularly in terms of, you know, impact measurement and the value that clinical engineers and health technology managers do, that can be almost immediately packaged into, as I said, a clear message that we can convey to stakeholders out there. So I would suggest that there's almost a group for each, because I think they're important in their own right. And then so as evidence comes from, call it the research group, the internal group, so much more the message to the outside world can be strengthened. So that would be my suggestion, that there are these activities, if you like, in these 2 parallel streams. But I would be very keen to work on the external group, external stakeholder group. As I said, there's a lot of low-hanging fruit that immediately can be put to good use. Thanks.
And it occurs to me is maybe the
We lost your microphone, Tom.
We've lost your audio,
senior
Tom.
advisors.
Oh, you're back.
All right, I'm sorry. It's maybe my desk. No, it's my phone. Anyway, I was just saying, maybe the 10-person teams work on the research, the internal, but the leaders of the teams and their senior advisors, and I mean, that includes you and Elliot, for example, working with credentialing and policy, you know, speak to the external messages, but I don't know, that's a structural answer. It may not be the right answer. Others? Oh, the question was in the air on how do we, in this early work, putting the framework piece together, how do we fold in the case studies? Some quick thoughts on that, maybe?
I have a couple of thoughts. And then I think I've shared my screen. Yeah, George, this is what I was looking at for my thesis, and I was very focused on the two bubbles, the two first bubbles on the left-hand side. I agree with you, Mladen. I think I know why you've made that last comment. It's important to try to share our success stories with the wider kind of health systems audience, to try and demonstrate basically the value. I think that very much will come out of the impact and the theory of change work, because I think most of those stories are more kind of on the right-hand side. So we're talking about actual impact on patient outcomes, on effectiveness of health services, et cetera. That's my thought, is that a lot of the external packaging of look at the value of this very much hangs out on the right-hand side of this model, which is the theory of change or impact work. And that on the left-hand side of this is where a lot of the work to try to describe maturity of services will come into play.
Very good. Shauna, do you have thoughts about the case studies as well?
Sorry, yeah, that's what I was going to say initially, which is the case studies also in my mind are very much on this right-hand side. They're related to stories about improved access to services, improved patient outcomes. So they're, in my opinion, they're very impact focused, or they're on the impact end of the spectrum, as opposed to the capacity building end. We know that the capacity building stuff underlies the impact, but they're, in my mind, all of those case studies hang out more in a kind of publicly consumable way, more on the right-hand side of this model.
And I think my follow-up comment to what you said, where I'm agreeing with you, is that the way we look at the theory of change, the way we look at the maturity model is through the lens of those case studies. Not any medical device, anything we might ever do, but it's through the lens of those case studies.
Yeah, I agree.
Okay.
Folks, I need to leave. Thanks for a great meeting.
Thank you.
Thanks,
Good
Mladen.
night. Mladen, I think you're mistaken. You can never retire, my friend.
Retired-ish.
It's just a short transition to what comes next.
Yeah, I'm probably having a retread and then back on the road.
Tom is talking to a mirror when he says that to you, Mladen.
I'm looking forward to my next lifetime on Earth, that is. Okay.
Cheers, guys.
All right, take care.
All right, folks, I think I'm happy to end this meeting now and give you back some time. Fabiola, though.
Okay, I think the diagram that Shona showed us, it's a key to organize the case studies. And I was thinking of the success stories we have collected and that have been reported. We may, well, this is my thinking, but we may have two versions of the case studies. One of them should be the relatory, the storytelling, like that will be helpful for disseminate into the audience. The light relatory of a story would be important to make awareness about the impact of the story. But we also need to have a structured case study in each storytelling, or in each success story, that make it more formal and official, and we should ask for evidence. It may be published, it may not, but at the end, the evidence should strengthen the case study. So we may think of a structure, general and minimal elements structure that help us to organize our case studies and make them fall into one of the two models.
And Fabiola, I know you don't need me to assign you homework, but can you try to do some first thoughts about that?
Yeah, of course, sure.
As the academic researcher with a lot of practical experience behind you. Very good. Any other closing comments? I think we've done enough good work for 70 minutes. Thanks, everybody.
Thanks a lot, everyone. Be well.
Thank you.
Bye-bye.
For everyone's
Bye.
hard work and insight.
Bye.
Thanks, everyone. That was great.
Thank you. Bye-bye.
Bye.
Yeah, have a nice day. Bye.